It's a pleasure to be here, and thank you, Dr. Ranko, for inviting me. I will switch gears and talk more about rescue therapy of Ecmo and CRRT in sepsis that we have not much data. So I will provide a brief overview of the topic for you. I'll start with my disclosures. I do have a grant support from the various institutions, including NIH. I also want to say that I practice as an intensivist in surgical ICU, and where I don't use much of the Ecmo because all my patients do very well. I prevent AKI and multi-organ system failure, and I also work as a nephrologist covering different units in ICU, and then I see a lot of patients on both Ecmo and CRRT. So just to brief overview for all of you, maybe not being so familiar with Ecmo, it's a type of mechanical device that aims to provide either partial or complete cardiopulmonary support. They started with a cardiopulmonary bypass that is mostly used in an operating room, providing complete cardiopulmonary support. Ecmo by itself provides only partial, either cardiopulmonary, if it's veno-arterial, or veno-venous. Ecmo provides only pulmonary support and has been now widely used in the US at least for support of refractory ARDS. We also have two other devices, extracorporeal CO2 removal for the partial pulmonary support and ventricular assist device for partial cardiac support. Now, two key trials really changed this field. The first one is in 1996. It was UK collaborative Ecmo trial group that published a study on it was a randomized controlled trial of 185 neonates demonstrating survival benefit and really changed practice for the pediatric population, especially neonates. And then CSR trial in 2009 was RCT trial for severe ARDS that were transferred either to Ecmo referral center or patients treated with conventional therapy. And that is an interesting trial because it did not show a difference in hospital mortality. It did demonstrate a survival benefit for patients who were referred to the specific Ecmo centers and really opened this field for the more widespread use of Ecmo in critically ill patients. And then there is ongoing OLIA trial for severe ARDS in the US, and we don't have results for that yet. Now, what are the modalities of Ecmo? There are two major modalities, veno-venous and veno-arterial. Veno-venous Ecmo really is more for the pulmonary support, and it allows diseased lungs to heal while a potential additional injury of aggressive mechanical ventilation is avoided. And you can see that the blood is removed from the venous system, CO2 is extracted, blood is oxygenated, and then returned to a venous system, and providing oxygen for the peripheral tissue. In veno-arterial Ecmo, the blood is drawn for the venous system, oxygenated and pumped back to arterial systems, so it also allows cardiac support and not just pulmonary. Notice that veno-venous Ecmo does not provide cardiac support. So what are the indications for the use of Ecmo? There are some more stronger and the weaker indications. I would say among cardiac indications, bridge for end-stage heart failure, towards heart transplant during the cardiac surgeries. In the severe heart failure, again, cardiac surgery. In the US, it's more increasingly used for what we called Ecmo CPR for the veno-arterial support, post-cardiac arrest patients, and then less indicated or less proven even in a study is the use for severe trauma and severe hemorrhagic shock. In terms of the pulmonary indications, mostly it's now used for the VV Ecmo is used for the refractory ARDS when all other therapies, rescue therapies fail. Also, it's used as a bridge for lung transplantation and primary graft failure following lung transplantations. Severe pneumonia, it's sepsis, much weaker, and you can see later in my review that the studies are sporadic, and then again, perhaps for use of the vagal granulomatosis for allowing some healing of the lungs and mechanical ventilation, secondary bowel injury. Now, when not to consider contraindications, really, this is all based on observational studies, and I would say opinions. So the evidence is not very strong, but most of the studies say that you should not consider Ecmo if the prognosis of underlying disease is poor. So the reasons listed are usually neurologic injury, intracranial hemorrhage, immunosuppression, irreversible multi-organ failure, Some studies will list advanced age. I put a question mark because I think using age as a contraindication is not a practice I would subscribe for, and then aortic dissection or severe aortic regurgitation. After CPR, if you don't have a definitive therapy, if your patient is not candidate for definitive therapy, they call that bridge to nowhere. Probably bridging with Ecmo, not a good idea. That's why careful consideration should be given to the cases where there is no definitive therapy after Ecmo. It is really a rescue therapy. So let's reveal some of the evidence for different contraindications. There are recent meta-analyses for different types of Ecmo that will show you where are we standing in terms of the prognosis and in the use of this rescue therapy. This is meta-analysis of the combined cardiac and respiratory indications for Ecmo, almost 2,000 patients. Most of these studies used veno-arterial Ecmo. You can see that they are younger patients with mortality during Ecmo is about 45%. I would say similar to the use of the CVVH. So multi-organ failure, no matter what kind of rescue therapy you use, patients don't do very well. Interestingly, you can see here the multi-organ failure with the kidney failure is almost 52% of the patients require also CRRT. The complications listed often in these meta-analyses is AKI and AKI requiring CRRT. The problem is deciphering whether this is before coexisting or post-ECMO failure. In my opinion, is probably coexisting with other organ failures, although some of the injuries could be secondary, but it is very prevalent. So what we see in ICU in a very severe critically ill patient is coexistence of the severe renal and severe respiratory failure, and those patients don't do very well. I would say this is regardless of the cause of by organ failure of lung, kidney. When you come to the support therapies, mortality reach about 55%. You can see the complications of the ECMO are severe. The most common are bleeding and ischemia due to the vascular access. Another meta-analysis of EV ECMO for the refractory ARTS, where you don't need to use arterial access, show a little bit less complications in terms of ischemia. In this meta-analysis, almost 1,000 patients, the mortality is less, about 38%, and AKI is unfortunately not listed or not reported at all in terms of how many patients require renal replacement therapy. Again, you can see that the complications are bleeding because of the need for anticoagulation during ECMO. Combining ECMO and CRRT. So how is it done? There are three major approaches for combining them. One is just to have independent CRRT, simple but not very elegant, obviously. Two other approaches are having inline hemofilter or having inline CRRT device. The inline hemofilter is a simple and cheap method. However, you cannot precisely measure net fluid removal, and there is no pressure monitoring. In an international survey of the centers, about 22% of the centers use this approach. Another approach is having inline CRRT device. This is apparently a little bit more elegant approach. It does, the connection depends on what type of ECMO pump you use. It provides longer filter life, and you can actually accurately measure fluid removal. About 51% of the dedicated ECMO center use this approach. In the same survey, the indications for CRRT during ECMO are mostly fluid removal. About 43% of the center lists fluid removal of the main indications for using CRRT. Prevention of fluid overload, about 16%. AKI itself, 35%, and other electrolyte disturbances, 4%. There is one meta-analysis of the combined use CRRT and ECMO when the studies explicitly list coexistence of two organ failures. About 1,000 patients is reported in this study. And you can see here that in all studies, whether they are case control or cohort studies, with the exception of the historical cohort from one study, patients who need both ECMO and CRRT do much worse. In other words, if you have two major organ failures, you don't do well, 55%. If you only have lung or cardiac failure and you only require ECMO without kidney failure, you actually do better, about 27% mortality in that group. What about using Ecmo in sepsis? It really is a rescue therapy. So what would the indication for Ecmo in sepsis would be refractory septic shock with either single or biventricular cardiac failure. And in newborns, in the children and newborns, it's a little bit different. In newborns, the persistent pulmonary hypertension and right ventricular failure is very common in sepsis. In infants, a left ventricular impairment and low cardiac output is still more prevalent than in adults, where we see mostly distributive shock and high cardiac output in the beginning. Refractory ARDS would be another indication that is most common in our center, really, in the setting of the sepsis. So the evidence behind the use of this therapy really depends on your age group. So in neonates, it is accepted therapy in a variety of conditions, including sepsis. So survival in neonates is about 80% for both respiratory and circulatory failure, and is not much different in a sepsis. It's about 77%. As you are getting older, like in older children and infants older than 30 days, the survival decrease when you use Ecmo in sepsis for both respiratory and cardiac failure. And we have some conflicting results in terms of the outcomes. What about adults? So surviving sepsis guidelines 2016 explicitly recommend that in patients with refractory hypoxia, alternative strategies such as APRV ventilation or Ecmo may be considered as rescue therapies in experienced center. I think it's important to recognize that Ecmo is really a rescue therapy, and that delivery of Ecmo probably is better done in centers that do have experience in delivering this therapy or have their own teams, like in our center. So what are the studies? Not many of them report their experience with Ecmo and in sepsis, and most of them do not report really on a CRRT. I think it's mostly reported as the coexistence of the organ failure in the septic shock. 3 main case control or historical cohort studies, 2013-14 from the Taiwan and France. The first one from Taiwan had 52 patients. Notice here that mean ejection fraction were about 55%, so these are not patients with a cardiac failure. 40% of them had Ecmo after CPR, and their survival was 15%, obviously very bad. Another study in 2014, similar population with a little lower EF, so more cardiac failure, you would expect more benefit, and obviously survival was higher, but again, CPR after 44% of the patients. And in their meta regression analysis, having CPR was independent predictor of poorer survival. So actually they recommend if your patient had CPR in severe sepsis, probably not a good candidate for Ecmo as a rescue therapy, so something to consider. And then the French study had the best result. They had 14 patients with refractory septic shock. They have a dedicated mobile Ecmo team. They only choose a specific hemodynamic profile. Patient has to have a low cardiac index, low EF, 16% on average, high catecholamine, and high SVR. So they are targeting a specific group of patients. They report 70% survival with rapid resolution of LV function within 5 days and severe ARDS. If the patient has severe ARDS, they would switch to venous Ecmo, and they report good long-term outcomes. So obviously, this study implicates that maybe we need to look for the specific phenotype of the patients who need this rescue therapy and then target that. So in summary, we don't know much. The use of Ecmo for patients with sepsis needs to be rigorously studied. We really need to recognize who needs this rescue therapy, which clinical phenotypes would benefit. We need more studies. The effect of using CRRT for fluid management during Ecmo also needs to be rigorously studied, because who needs the removal, how much removal, which technique, and how that needs to be measured, we don't know that yet. The effect of CRRT treatment for AKI during Ecmo, again, needs to be standardized. It's all over the place in the studies and needs to be rigorously studied.